The things to watch out for are jaundice, by which I mean yellow discoloration of the skin and the eyes, which is usually accompanied with itching of the skin and passing dark urine. So that's called obstructive jaundice. So that's often one of the first signs of pancreatic cancer. The other things to watch out for are pain in the tummy, in the upper part of the tummy and in the back, unexplained weight loss, diarrhea with pale, fatty stools, a recent onset of diabetes, especially along with any of these other symptoms, and finally, an unexplained attack of pancreatitis. Those are the common symptoms of pancreatic cancer. And in terms of what you might find in the patient, a lump in the tummy is often the first finding, apart from the jaundice. Pancreatic cancer is one of the more common cancers now. There are about 7,000 people diagnosed in the UK every year with pancreatic cancer. It's common in older people. It's slightly more common in males. It's slightly more common in smokers. There are some genetic factors and medical conditions that can increase the risk of developing pancreatic cancer. Some people have a family history of the disease. And if you have 2 first-degree relatives with this cancer, then you're at a slightly higher risk compared to the average population. In a few high-risk families, there may be a mutation of the BRCA2 gene. Some people who suffer from hereditary pancreatitis have a higher risk of getting pancreatic cancer. People who have chronic pancreatitis or chronic inflammation of the pancreas are at a higher risk. And occasionally there are some cancer syndromes, such as Lynch syndrome or HNPCC, which are associated with a high risk of pancreatic cancer. I think it's important to not neglect any of these symptoms and seek advice promptly. Pancreatic cancer can be notoriously difficult to diagnose, and very often patients who present with abdominal pain or jaundice might go down the path of having an ultrasound, having an endoscopy, because people are thinking about gallstones, people are thinking about peptic ulcers, which are the more common problems. And it is only after the patient has had a CT scan of the abdomen that the diagnosis becomes clear. So I think it's important to take your symptoms seriously, see your GP, and I would expect that you would have blood tests done, which would include liver function tests. There is a particular tumor marker for pancreatic cancer called CA19.9, which may be useful in some patients to make the diagnosis. And while ultrasound scan is often the first scan that people go for, it is a CT scan that usually makes the diagnosis. So if there's any suspicion, I would push for an urgent CT scan of the abdomen. The diagnosis is made on a CT plus or minus other tests like MR, ERCP, which is an endoscopy where you might put in a plastic stent or a metal stent to unblock the bile flow and take tissue samples. So once all of these tests have been done and a diagnosis made of pancreatic cancer, it depends on what the stage of the disease is. So is it confined just to the pancreas, or has it spread beyond the pancreas, but still locally, just around the pancreas in the surrounding tissues or the lymph nodes? Or has it gone beyond the pancreas away to other organs like the liver or the lungs or elsewhere in the body? Patients who have the cancer confined to the pancreas or its immediate vicinity, if they are fit and well and able to withstand an operation, then we would recommend that they should have an operation. And that could be what's called a Whipple's operation, where the head of the pancreas is taken away, or a distal pancreatectomy, where the tail of the pancreas is taken away. So the pancreas is shaped a bit like a club with a head and then a body and tail. So depending on where the cancer is located, you might have the head removed or the tail removed. And they're two slightly different operations. So that's surgery, which is recommended if the disease is identified in the earlier stages. If, however, it has spread, then the next step is usually chemotherapy or drug treatment. And there are various possible chemotherapy regimens that are available, and that is something one would have to discuss with the doctors looking after the patient. And after the chemotherapy, in a few instances, there might be the option of then going to surgery, but in some others, there won't be the option of that, but you continue with chemotherapy for a longer period of time. You can answer this at several levels. One is, if you have an operation, what are the chances that you will survive that operation and come out of hospital? And that figure is somewhere in the region of 97 to 98% for most of these operations. So you'd expect 97 to 98% of your patients to survive the surgery and go home. The next question is, will they be cured, or what is the 5-year survival following this operation? So that is a more challenging question. If it is pancreatic ductal adenocarcinoma, which is the commoner form of pancreatic cancer, then if someone has had surgery and then followed on with chemotherapy, you're probably looking at somewhere between a 30 and 50% chance of a 5-year survival. So a 1 in 3 to a 1 in 2 chance that they'll be cured of their disease. There are, however, many other conditions which also fall under the umbrella of pancreatic cancer. For example, ampullary cancers, which are cancers that arise in the bowel, but at the point where the pancreas is opening into the bowel. Or neuroendocrine tumors of the pancreas, which are a slightly unusual type of cancer that also arises within the pancreas and often makes hormones. So those have an even better prognosis, and you've got 5-year survivals that range from 40 to 50% for ampullary cancer to 60 to 70% for neuroendocrine tumors. So there is a proportion of patients who will get cured, but there is a proportion of patients who will not be cured by surgery. In the group of patients who do not have an operation, but who have chemotherapy, the chances of a cure are much lower. But we do see a lot of patients responding to the chemotherapy, especially with the newer regimens. There are up to 50% response rate. So you see the tumor shrinking and the patient feeling better, although it doesn't lead to a long-term cure. It will buy the patient more time and make them feel better in most instances. One patient comes to mind. She had a scan done and it showed a tumor in the body of the pancreas. And I was very concerned that this was a malignant tumor. And when I contacted her to say, I need to see you urgently, she was actually not very keen to come in and said, look, I've got a lot of other commitments. She had a lot of animals that she was looking after, and I need to sort out my animals. I cannot come in now. And I listened to all of that. And then at one point I said, look, I wouldn't have rung you if this was not urgent. You need to sort all those other things as soon as possible and come and see me. This cannot wait. She then realized that I was talking about something very serious. She came and saw me the next week. We proceeded to surgery the week after. That was 7 years ago. She went on to have a distal pancreatectomy. So the body and tail of the pancreas was surgically removed. She then went on to have chemotherapy, or adjuvant chemotherapy, to follow up the surgery. And 7 years later, she remains free of her cancer and is very well and continuing to look after her animals. So prompt action in a patient who fortunately had operable disease resulted in a cure.